Yeah.
So good evening to one and all present here today for the awareness session on updates in cardiology and also cardio related diseases that we are seeing now. As of now, we know that there are n number of diseases or the conditions associated with the heart health. Today, we have our eminent speaker, Dr. Anup Charles from Frontier Lifeline Hospital, commonly known as the Dr. Cherian's Hospital today. So, doctor will be giving us a detailed update on CVD. What are the awareness things that we as a common people and also a medical professional should be knowing, and also what kind of lifestyle changes we need to get it done. Over to you, Dr. Anup Charles.
Yeah, thank you, Samya. Thank you. So, good evening and welcome to all the participants. Am I audible? Yeah. Okay. Good evening, all the participants and esteemed colleagues who have joined us in the Zoom meeting. And thank you, Samya, for introducing me to the honorable guests out there. I am Dr. Anup Charles. I'm a consultant cardiothoracic and vascular surgeon and specialized in pediatric cardiac surgery. At present, I am a consultant in Frontier Lifeline Hospital, Chennai. It's also known as Dr. K.M. Cherian's Heart Foundation. Here we do mainly all kinds of surgeries, interventions, and non-interventional treatment for cardiovascular disease. It's mainly a cardiothoracic and cardiovascular institute, which is known internationally. And we are doing a good job in Chennai. And today, the topic assigned to me to talk to you is about the COVID-19 and cardiovascular diseases, how it affects the common man, and how we came through the COVID-19 and all the cardiovascular problems along with that in the past 2 years. So I will take you through to a different aspects about the cardiovascular risk factors as well as the diseases and as well as the management in the COVID-19 situation. It is more, I thought it was more of a participant will be more of doctors. So I thought the presentation is full of medical terms. In case some people don't understand, you can always come in the chat box and send us the question so that at the end of the session, we can always answer to them in the common language. Otherwise, most of the terms and terminologies are well known with the doctors rather than the general public. So I'll apologize for that. And we'll go through the details of the this topic. In the last 2 years, we saw a very rampant and very problematic situation that we all went through. It's called as COVID-19 pandemic. We all know it was due to a coronavirus, which is an RNA virus, and which created an havoc in all the fields, especially in medical field, and also in cardiovascular problems. In cardiovascular diseases, the COVID-19 situation created a lot of confusion as well as a lot of panic. We didn't know how to treat it, how to manage, how to diagnose. And in the other consequence, we had so many loss of life, so many unfortunate events happening in the last 2 years. Now, being experienced in seeing all those conditions and various situations, we're in a better place, we're in a better position to treat when we come across some patient with cardiovascular disease suffering from COVID-19. So for simplifying the things, I've divided this COVID-19 and cardiovascular disease association into 4 different groups. The first group is COVID infection in patients who already has cardiovascular disease. In the second group, there is a cardiovascular disease occurring in patients who are having COVID infection. For example, they didn't have any cardiovascular diseases earlier, but now because of the COVID infection, they have got cardiovascular diseases. The third group is cardiovascular diseases in patients who have recovered from COVID-19. They didn't have any cardiovascular events during COVID-19 infection, but when they have recovered, now they are experiencing cardiovascular diseases. And also cardiovascular diseases in people after vaccination and convalescence from the COVID-19 infection. Now, briefly into the pathophysiology of COVID, because it is very important for us to understand what exactly is the COVID infection is going to cause in order to understand the disease, in order to understand how to tackle it. This coronavirus infection involves SARS-CoV-2 binding to the host antigen converting enzyme receptor. These receptors are in the cells, body cells, where this virus goes and attaches to the cells and causes various kinds of events. Mainly, these ACE2 inhibitor receptors are expressed mainly, they are present mainly in the lungs, heart, and blood vessels. So, the most of the COVID infection, after the COVID infection, the affected organs are lungs, heart, and blood vessels. So, this is how the cardiovascular diseases are more prominent in COVID infection. Now, because these are the receptors which are responsible for the binding of the SARS-CoV, the COVID virus. So this, how does it bring about? This COVID virus likely involves dysregulation of the ACE system. That is, these are the receptors involved in blood vessels which can cause hypertension. Overactivation can cause hypertension, as well as a kind of inflammatory process in the blood vessel which causes acute occlusion or thrombosis inside, that is clotting in the blood vessels. So patients who are having hypertension are given medications to block these receptors. And it helps in modulating the cardiovascular abnormalities in the normally cardiovascular disease patients. So these are the main important pathophysiological changes that occurs in COVID-19. Not only blood vessels, the SARS-CoV-19 virus infects the human cardiomyocytes. Cardiomyocytes are the heart cells, cells within the heart, which are stem cell derived ACE2 or capsid dependent manner. That means there are ACE2 receptors as well as cathepsin receptors. So these receptors are responsible for direct injury of the cells in the heart. The cardiovascular comorbidity in COVID-19 may be either primary, that is, or secondary due to acute lung injury. Primarily, it can affect the heart, or secondary to the lung injury, it can cause increased cardiac workload and causes heart failure. There will be increased oxygen demand, but oxygenation is not adequate in COVID-19, and because of the lung involvement, and then they can have secondary heart involvement. Then also something called as neurophilin 1 can facilitate COVID cell entry and infectivity, but the significant process is not very unclear, is not very clear in cardiovascular disease. But however, this process can happen. The fourth thing is the cytokine storm, originating from imbalance of T cell activation with dysregulation of interleukin-6 and other cytokines. Cytokines are some kind of proteins which are in the blood, which is a marker for inflammation. So when there is increased release of interleukin from mast cells, the cells which are responsible for immunity, they release interleukins. These interleukins cause intense vascular reaction in the body. It is called a cytokine storm, and patient with a severe COVID infection can directly have the cytokine storm, and they can have hypotension, and suddenly they can have issues. Another thing is immune system activation. It is also called as immunometabolism alteration, may result in if somebody is already has got a minor disease in their blood vessels, can have the plaque instability, that the occlusion can become unstable, and there will be atherosclerotic changes in the blood vessels, and there will be atheroma. Suddenly that atheroma can become unstable, and the plaque can rupture and cause acute coronary syndrome. Acute coronary syndrome, where there is an acute heart attack, either in the form of ST elevation or non-ST elevation, we call it as. So they can have acute heart attack, and immune system activation can cause immunometabolism alterations, which can result in acute coronary events. So just to summarize, I have put this diagram to summarize the cardiovascular involvement in COVID-19. The SARS-CoV-2 virus enters into the cell through the ACE2 receptors, and they can bind to the ACE2 receptors which are present on the heart, muscle, blood vessels, everything. So there can be changes in the microvessel where there is capillaries and arterioles and venules, where also can cause hypercoagulability, which can result in deep vein thrombosis or acute arterial occlusions, formation of thrombus in the arteries, as well as pulmonary arteries, which can cause pulmonary thromboembolic phenomenon, where the clots can go into the main arteries of the lungs. That is called as pulmonary embolism. The microvascular changes can cause microvascular dysfunction, which can result in endothelial dysfunction. This inner cell lining of the blood vessels are damaged. The coronary arteries are the arteries present on the heart. So these arteries, they can have endothelial dysfunction, which can result in acute heart attack. That is called as acute coronary syndrome, where you can have, when you do an ECG, you can have ST elevation, or there may be some ST changes with enzymatic changes, which can result in heart dysfunction. So the viral invasion into the lungs can cause inflammatory changes in the lung and cytokine storm, which can make the plaque unstable and can cause acute coronary syndrome. Or if the inflammation is too strong on the heart muscle, which can cause weakness of the heart muscle and can cause heart failure. So this inflammation of the cytokine and the inflammatory changes can also cause myocardial damage directly on the heart, which can result in heart failure, or the direct injury to the myocardial cell can cause arrhythmias. Arrhythmias are some when there is normal heartbeat is called as normal rhythm. The abnormal heartbeat like this can happen when there is injury to the cardiac cells. That is called as arrhythmias, which can be seen on the ECG. Now, coming to the COVID-19 in patients with pre-existing cardiovascular disease, the situation is there is a patient who was already having a cardiac problem. For example, a patient who has already had a heart attack, or the patient already has some kind of congenital heart disease, taking medications, or had surgery before, now waiting for second stage surgery, or they have a congenital heart disease where they have been monitored for some kind of intervention later, or they're having a cardiac problem with, they already have borderline heart failure which they are on medications. They already have some kind of valvular heart disease, rheumatic heart disease. They have got mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation, etc. Waiting for some kind of treatment, or some treatment has been done, intervention has been done, and they're taking medications. Or some patients with hypertension, diabetes, multiple risk factors and comorbidities with pre-existing heart disease, like diastolic heart failure, or systolic heart failure, or arrhythmias, on pacemaker. So these are all the patients who are already having cardiac issues. Now they contracted COVID-19 infection. So this is very important for us to know beforehand what was the problem they were suffering from. Because COVID-19 infection in this kind of patients may become very severe, and it can lead to a lot of morbidity and mortality. So multiple studies have demonstrated that comorbid cardiovascular disease is linked to more severe COVID and higher mortality in COVID-19. So we should be more careful in such patients who are having cardiovascular disease. Better is to have strict isolation, strict protocols for hand washing, mask, and physical distancing. This to prevent. Once they get COVID-19, you should be more cautious that it should not aggravate the existing cardiovascular disease. In that case, we should be more aggressive in treating the cardiovascular diseases along with the COVID. There was a meta-analysis by Filigrossi et al. Showed the cardiovascular disease triple the odds ratio, 95% confidence interval, occurrence of severe course of COVID-19, which was defined as death, COVID-19 infection, hospitalization in intensive care units, as well as use of mechanical ventilation and progression of disease. So these patients were seen as more vulnerable to get into ICU And these patients were more vulnerable for mechanical ventilation as well as death. And congestive cardiac failure was defined as both risk factor for a severe course as well as increase in morbidity and mortality. In all the cardiovascular disease patients, patients who have already had heart failure were more susceptible for sudden death as well as severe COVID infection and death in the ICU. Tomasoni demonstrated that patients with history of heart failure are significantly poorer outcomes with higher mortality in hospital complications. So these were the patients who landed up in the hospital and they never recovered. Now we have the understanding. So at the beginning itself, patients have heart failure and milder COVID infection. They are more aggressively managed by isolation, monitoring, as well as escalating the medications, as well as the diagnostic modalities we use, like doing an ECG, doing a CT scan and CT scoring as early as possible, getting viral markers, getting their antibodies tested. More so now, prevention in case of cardiovascular risk factors, we have vaccinated them as early as possible so that they can develop the immunity towards COVID-19 infection. It is better not to contract COVID infection for patients who are already having pre-existing cardiovascular disease. When they contract, it is always better to go upfront more aggressively ahead to treat COVID infection as well as the cardiovascular problems before they get into heart failure. So double and triple mortality rates were seen when heart failure patients had COVID infection. So other cardiovascular risk factors in COVID is diabetes mellitus. Now diabetes mellitus is one of the main important comorbid conditions where people with COVID-19 infections had aggressive course. Diabetes seems to be exacerbating the underlying pathophysiology of hyperglycemia in patients with diabetes. A whole population study in England revealed that COVID-19 deaths were 3.1 in people with type 1 diabetes and 2 in people with type 2 diabetes. There's 2% death in patients who had type 2 diabetes. This is a high number because for every 100 patients who had diabetes, 2 patients died with COVID-19. So this is the inference we get. So proper diabetes control was very, very important during COVID-19 pandemic. There were many problems because patients were unable to get them tested, come to the hospital and getting medications online. All these things were happening. In those situations, the patients didn't have a good diabetes control. This was a reason for increase in blood sugar levels, as well as when they contract COVID-19, when the blood glucose levels are not under good control, they develop having cardiovascular diseases, stroke, acute acute myocardial infarction, acute coronary syndrome, acute renal dysfunction because of prolonged diabetes. Now, because of COVID cytokine storms, they ended up having acute renal dysfunction, and patients are all died because of that. Another risk factor is obesity. Now, obesity is always linked with the cardiovascular risk factor, mainly the central obesity, where patients are having the high BMR, high BMI, as well as patients not exercising, individuals who had obesity was having an increased incidence of having COVID-19 because they also had poor lung reserve, and also they had, because of the large body surface area, the cardiac output was required was more, and patients with COVID-19, had low cardiac output kind of a situation where they could not manage the demand and supply ratio. So the increased severity and higher mortality rate was also observed in obese patients. There was a pooled analysis done in one of the studies where 399,000 patients were diagnosed in COVID. Individuals were diagnosed in with COVID-19. Out of them, the hospitalization and ICU admission were about 2 to 3%, as well as mortality was about 1 to 2%, which is high confidence level. The other important thing is hypertension. Hypertension is one of the most important comorbidities in COVID-19 patients. A meta-analysis concluded that presence of hypertension significantly increased the odds ratio for severe positive uh, COVID-19 mortality. Because as I told you, angiotensin converting enzyme receptors are very important for regulation of blood pressure. This COVID-19 virus also used a similar channel to enter into the blood vessels. So the patients who had hypertension, prolonged hypertension, uncontrolled, were already at risk factor for cardiovascular disease. Now contracting COVID-19, there were multiple interactions of antihypertensive medications that they were using, as well as the blood pressure being not controlled. They were at more risk of having morbidity and mortality. The other thing is chronic renal dysfunction. The patients who had already had some kind of renal dysfunction, who are borderline maintaining without dialysis, or maybe once in a week or twice in a week dialysis, contracting COVID-19 infection, they were pushed to end-stage renal failure, and they were also more risk of having infections or then repeated dialysis and death. The chronic disease is another comorbidity where severe COVID-19 infections have occurred. They estimated that the glomerular filtration rates were much lower in COVID-19 patients. So patients who contracted COVID-19 were on dialysis, required more dialysis, more intense dialysis, as well as they experienced more problems and death. Now, coming to the diagnosis part of COVID-19, cardiovascular disease, there were stages where the symptoms of COVID-19 were almost similar to the disease symptoms of the cardiovascular diseases. Most of them presented with the chest pain, breathlessness, as well as low blood saturation. These are the symptoms of COVID-19 as well as cardiac problems. So there always existed a confusion whether the COVID causing cardiovascular disease or cardiovascular disease was there and COVID has got now infected. So this kind of differentiation was very, very important while managing this patient. So this diagnosis of COVID-19 relies on combination of epidemiological criteria. For example, a history of contact, incubation period, presence of clinical symptoms, as well as the laboratory testing. We started using the rapid antigen test as well as the nucleic acid test for amplification of RNA virus, that is the RT-PCR technique, and also image-based. Imaging also played a very big role where we diagnosed the epidemiological tests were negative, but the imaging parameters like CT scan showed us whether the patient really had COVID-19 infection or not. So, a combination of all these three things, the epidemiological data, the clinical symptoms, the contact history was very, very important for us to know whether there was a COVID infection in the pre-existing heart disease or the COVID-19 has caused the heart condition. And this was complemented well with the laboratory testing, like the rapid antigen test, RT-PCR, as well as the CT scan of the chest. Worldwide, we had one major important breakthrough in the diagnostic arena was the nucleic acid amplification test, which is also called as reverse transcriptase nucleic acid test, which is RT-PCR, polymerase chain reaction test. RT-PCR, this is the gold standard test to detect the COVID-19 infection. But there were some pitfalls in the diagnosis. Pitfalls in the sense the sampling errors were there. Sometimes the transportation of the samples were not proper, and we had false negative tests in the initial stages. Now, because of the standardization and as well as because of the we knew what problems were faced by results, so we control now, and most of the RT-PCR tests we take are mostly very effective and very sensitive and very specific. Now, Uh, Testing should be for now. Initially, we always used to do the RT-PCR test as well as the rapid antigen test and say if it is negative. Then, if symptoms persisted, we always went for a CT scan and to see what kind of lung lesions they had and things like that to find out. Um, Now also it's the gold standard. Whenever you suspect any patient coming in with cardiovascular symptoms which are not very much attributed to the underlying condition. For example, patient comes with breathlessness, cough, and low saturation. You do ECG, X-ray, echo. They more or less they're all okay, but they don't match with the clinical symptoms. Then you always suspect that there is something other than the cardiovascular problem. So then we always test the RT-PCR and see if patient is having COVID. Then if COVID is present, then we'll try to treat it along with the cardiovascular symptoms. Now, also we have now another entity called post-vaccination COVID. So the patients who have already had vaccination, but still they can come with COVID symptoms. Because of the changing strains and changing pattern of COVID virus, the different strains have come. Now, so to know whether they've got immunity for COVID-19 or not, we do an antibody test called IgG and IgM antibodies, which are enzyme-linked immunosorbent assays. Now they are widely used. And in spite of having antibodies, if they still have COVID positivity, then it is considered that they have got another strain of COVID-19. So we treat them. So rapid antigens can also contribute to overall COVID-19 testing. Now, for example, if somebody wants to undergo a procedure, but they've already had a COVID-19, but you don't know whether it is risk active or not. In those cases, rapid antigen tests can help you to differentiate as well as to go ahead with the procedure or not. Another important is cardiac image. The lung CT played a very important role in differentiating from COVID from primary lung pathology or primary cardiac pathology. So this is a flow chart where it shows how COVID-19 and cardiovascular disease coexist. For example, there is a patient with cardiogenic shock. A patient, is come with a cough, chest pain, and if you see his pulse is not recordable or very low blood pressure, saturations are very low, all lung signs are present, and the patient is not producing correct and adequate quantity of urine. The patient is in cardiogenic shock and possible COVID-19 infection. What you're supposed to do? You have to acute decompensated heart failure is the first diagnosis you have to make. And immediately should suspect if there is a myocardial infarction, do an ECG, do an X-ray, do an echo and see what is the cardiac function. Then relative hypotension and tachycardia immediately start spinal tap. Simultaneously, you should always test the patient for COVID-19 infections. All heart failure patients coming in decompensated heart failure should be tested for COVID-19 in the OR. And always use personal protection equipment as well as kit, and use a dedicated center, dedicated beds for receiving those patients so that we can isolate them and become positive. Once the shock is confirmed with all the diagnostic tests, treat as infected, monitor and differential diagnosis with sepsis. If COVID-19 confirmed, then it should be treated as COVID-19 along with heart failure. So they should be isolated and they should be treated with aggressively treated for both heart failure as well as COVID-19. So cardiovascular disease, now that part is over. Now coming into the patients who are young, who didn't have any cardiovascular diseases, now they had COVID. Because of COVID infection, now they have got cardiovascular disease. The COVID virus itself can cause many things. Like for example, it can cause acute heart failure, decompensation, or new onset heart failure. Second thing is acute coronary syndrome. Acute coronary syndrome involves both ST elevation MI and non-ST elevation MI. Third is a venous thromboembolic phenomenon or arterial thrombus. Both have been seen. They can have arterial as well as venous thrombosis in COVID-19, which can cause deep vein thrombosis or peripheral vascular disease as well as pulmonary thromboembolism. All these three, four things have been seen. And the other thing is arrhythmias. They can have tachyarrhythmias. Most common are the ventricular tachycardia and atrial fibrillation. The bradyarrhythmias are much later, not at the infective stage. Sometimes they can have, but more frequently we have seen it after the infection and after the recovery, where the myocardial cells have become fibroid and they can have bradyarrhythmias. Bradyarrhythmias are slower heart rate, a complete heart block, first or second degree or third degree complete heart block, and they can have prolongation of QT and PR intervals. These are seen after COVID infection. This is mainly because of the infiltration of COVID antibodies and antigen antibody reaction cardiac cells, which results in myocardial fibrosis, as well as because of medications for COVID-19. Some bradyarrhythmias are known due to medications like azithromycin, which can prolong QT, and as well as the chloroquine, hydroxychloroquine, which were used for COVID-19. Now, patients presenting with cardiogenic shock, how do we have to manage in hospitals? Detection of COVID-19 respiratory specimen upon admission is mandatory. As I told you, throat swab has to be done for RT-PCR or rapid antigen to immediately know whether if rapid antigen is positive, then probably you are dealing with suspected COVID patient along with cardiogenic shock. So you have to confirm it with RT-PCR, no doubt about it. Anyway, you have to consider them that potentially they are infected until the test of RT-PCR comes. So they should be managed in a separate bed where they are isolated from the negative patients. Okay. So once the SARS-CoV-2 RT-PCR results come, if it comes negative, it is automatically transferred into the negative zone where CCU is well-equipped trained staff is there, and fever or clinical signs of infection is still there. To retest after 24 hours once more. If there is no second test report is negative and there are clinical signs of sepsis, then it should be treated as sepsis. If it is positive, either your hospital should have a place where it is dedicated for COVID patients to be treated, or it should be transferred to the place or a hospital where the COVID-19 isolation facilities are there. Well-equipped, trained staff, there is protocols and restrictive. The movement should be restricted from other persons for contact. No? And also, the prognosis of cardiogenic shock should be kept in mind. Suppose you have an irreversible cardiogenic shock with COVID-19 infection, which is very severe. More conservative approach should be taken rather than having an aggressive. For example, there is a cardiogenic shock which can be reversible by doing some intervention. You should always try and see if you can put them on ECMO. Otherwise, it should not be done. Now, this is the most common scenario we see in COVID-19 patients coming with the ST elevation MI. ST elevation MI, you know, as it is an acute emergency where patients have to be treated immediately receiving. So they go into the CCU. Once the patient confirmed that there is ST elevation MI, it should be transported to the hospital where it can have a primary intervention done. During this transport, the nasal swab or reaching the hospital, the nasal swab has to be collected for rapid test. If rapid test comes negative, then the patient is stable clinically and the ST elevation persists. If the facilities are permittable, if the hospital has the facilities for primary PCI, will be taken for primary PCI. If the rapid test becomes positive, if you are waiting for RT-PCR, then you should undergo some kind of thrombolysis. Okay, and then thrombolysis, then prepare. If artificial comes negative, prepare them for primary PCI. Now, the second scenario is self-presenting in COVID, hospitalized patients in COVID-19. Cath lab services, if it is present, they go for primary PCI. If it is not present, they go for fibrinolysis. Okay, and then later go for primary PCI. So, if the patient has to be treated by primary PCI, better to have a rapid antigen test and should have the data of contact as well as the demographic data of the patient so that we can distinguish from ST elevation MI without COVID and ST elevation MI with COVID. Again, for non-ST elevation, it's the same thing, but little difference in the sense, little more conservative approach can be taken up rather than the when compared to the ST elevation MI. If it is very high risk, hemodynamically unstable, recurrent chest pain, refractory to medical therapy, life-threatening arrhythmias, mechanical complications of myocardial infarction like VSR, VSD or MR, or acute heart failure, recurrent intermittent ST elevation, they all have immediately to undergo a invasive testing as well as primary PCI as early as possible. If they are high risk COVID, established diagnosis of ST elevation MI, at least of one of the following: dynamic SCT changes, recurrent symptoms, test for COVID. If test is negative, then they go for early invasive therapy. If test not able to confirm, they go for non-invasive testing like CT scan. Then they can go for PCI or thrombolysis. There is intermediate risk. Then diabetes mellitus, insufficiency, LVF is 40%, early postoperative angina. They can, as well as wait, they get tested and wait for PCI or surgical revascularization. Very low risk. Then they can test for COVID-19. Then they can go for non-invasive testing, CT scan. Then they can have either primary PCI, adult PCI, or wait for CVD depending upon the type of patient they have. The other group of patients are chronic coronary syndrome. The patients who are having chronic stable angina and are on medications and waiting for their turn for CVD or wait for adult PCI or something of that sort, or recanalized coronary artery syndrome. They are generally low risk for any cardiovascular events. So rather than directly jumping onto intervention procedures, better to have a medical therapy and should be optimized, and it should be intensified depending on the clinical status, rather than jumping on and doing interventions to suspect COVID-19 in chronic coronary syndrome. If they have anything to be relative new lesions, new onset angina, new onset arrhythmias, or anything of that sort, for primary coronary interventions. Then remote clinical follow-up should be warranted to reassure segment. Those who are having chronic stable angina and continue to having some kind of anxiety whether they after contracting COVID-19, they should be monitoring clinical status with an isolation, probably with a maybe some kind of online consultation or telemedical help can be taken, and they can be monitored at home in isolation. Coming to non-invasive testing. Non-invasive testing can be used based on a clinical scenario. You do a clinical, epidemiological testing like RT-PCR or rapid antigen test, and you're still not satisfied seeing the patient's clinical symptoms. You can always order for a non-invasive testing. For example, a patient with chronic stable angina presents with acute chest pain for about 30 minutes, borderline SCT changes, enzyme changes, but you don't want to take them for invasive testing like coronary angiogram. You can always do coronary CT angiogram. And also this can avoid unnecessary exposure to staff as well as the relatives. As well as the healthcare workers. know. But even though it's a non-invasive test, it is a kind of exposure for people who are working primarily, who are working in the CT scan area. So judicious use should be ordered. Now, coming to invasive assessment and revascularization, all symptomatic patients with very high titers, they are high likelihood of having acute pulmonary syndrome should be referred to the intensive care unit and should have an invasive cardiac assessment, as well as a dynamic assessment. But it should be after at least one rapid antigen test. For clinically unstable, especially are heavily overloaded, their healthcare system is heavily overloaded, patients can be patients can be referred to the center where intervention done. Revascularization either by PCR or by coronary and bypass grafting can be postponed in most patients who have chronic stable angina. Healthcare system might identify towards the hospital service as hubs for selected patients. And invasive and surgical cannot be postponed. For them, should have a place where they don't take any infected patients, but they do coronary as well as cardiac vascular interventions. For patients who are tested negative, should refer them for treatment. In selected patients, the hybrid revascularization can be done either CVD or PCIs. Even full PCI can be considered by the heart team based on patient clinical condition and local situation. So if you have a local heart teams, they can always discuss the case as well and take up for either elective PCI or coronary artery bypass graft once they are negative. Now, other state situation is COVID myocarditis. COVID-19 infection can cause direct inflammation of the myocardial cell, which is also called as myocarditis. The mechanism is quite unclear, but as you know, that ACE receptors are present on the myocardial cell. That is one of the ways how they can create myocardial cell damage. This is already proved by endomyocardial biopsies, as well as increase in biomarkers like troponins, as well as the CGST changes, as well as the echocardiographic changes. There is a loss of function, deteriorating LV function, as well as some myocardial injury markers like biochemical markers as well. Clinical features vary. Some patients present with fever, dyspnea, and acute onset of chest pain and hemodynamic instability. They can have hypotension. They can have cardiogenic shock. In more severe cases of pulmonary myocarditis, cardiogenic shock has been described. And this is the acute setting. Later, when it becomes chronic, they become like chronic myocardial dysfunction. Slowly, like vital myopathy, they slowly tend to recover for a period of time with medications as well as proper follow-ups. Now, patients with septal device and heart transplantation. The elderly patients are fragile. Every measure should be done to prevent viral transmission in them. They should be isolated. They should take precautions for social distancing, hand washing, all those things. And cautious monitoring of the anticoagulation therapy, this antiviral medication as well as anticoagulant medication. If technically feasible, this assessment of LVI function should be done on telemonitoring rather than calling them for hospital. Then a patient with valvular heart disease, aggravates COVID-19 aggravates the hemodynamic picture of the valvular heart disease patient, especially patients who have aortic stenosis, mitral stenosis, mitral regurgitation, and aortic regurgitation. These patients are vulnerable for decreasing heart function and having those are in class 1, class 2 NYHA and some class 4, which may require hospitalization. Elective surgical or transcatheter interventions for valvular artery is again a very confusing situation where inappropriate measures might have been taken. Might have been taken as well. Now, because of heart needs and each case can be discussed when they have positive bone infection as well as heart valve disease. The heart team can decide whether the patient will need urgent catheter-based intervention or may need urgent surgery or can be waited upon with medication so that for 15 to 20 days post-COVID infection, an ideal time to intervene. The acute pulmonary embolism, we have seen many cases coming with acute pulmonary embolism in the COVID situation. Especially when they have COVID and they convulse of the second or third week, when they're convalescing from infection and they're recovering, they have hypercoagulable state where they can have pulmonary embolism. Any unexpected respiratory worsening, unexplained tachycardia, or in blood pressure, not attributed to tachyarrhythmia or hypovolemia or sepsis, ECG changes, D-dimer studies, as well as the imaging shows deep vein thrombosis or any thrombus in any extremities like vessels like femoral artery, iliac vessels, or it can actually show you the thrombus load in the pulmonary arterial circuit. So when they are diagnosed with acute pulmonary embolism, either they have to be subjected to surgery or thrombolysis depending upon the trauma situation or the imaging immediately. Now, arrhythmias. Arrhythmias in COVID-19 is one of the most significant things happening, especially tachyarrhythmias. Most commonly seen are supraventricular tachycardias. Still, in COVID-19, the drug of choice is intravenous adenosine. For chronic, for the maintenance therapy, it's the beta blockers, the mainstay. And the other thing is atrial fibrillation. Atrial fibrillation can be chronic or new onset. In chronic atrial fibrillation, both amiodarone as well as the anticoagulation with heparin and switching over to oral anticoagulants, vitamin K antagonists have been used. They still hold good. And for flutter also, amiodarone is a drug of choice. So new onset atrial fibrillation episode, this is a flow chart we have for the European Heart Association guideline, European Cardiac Society. There is acute treatment of atrial fibrillation. Hemodynamics is stable. Then go for rate control using amiodarone, beta blocker, or digoxin. And along with that, use anticoagulation, preferably oral anticoagulant, to maintain INR between 2.5 to 3.5. If hemodynamically unstable, then we have to anticoagulate with heparin and go for a synchronized cardiovascular. And once reverted, they can be put on chronic maintenance therapy of amiodarone and or beta blocker depending upon the hemodynamic sensitivity. In case you suspect any coronary issues, the patient has to undergo a coronary angiogram. Targeted potassium. Bradyarrhythmia. In case of persistent severe symptomatic bradycardia due to atrial blocks or sinus dysfunction have been seen in cardiac in COVID-19 patients who have undergone, who have gone through COVID-19 infection and they are recovering from COVID. For them, all drugs causing bradycardia should be stopped. For example, if they are on chloroquine, azithromycin, which can prolong QT, and FDR involved should be stopped. You can also try with aclopine and isoprenylate infusion, or temporary pacemaker implantation should be considered in very slow heart rate, less than 45. A new onset severe symptomatic aortic dysfunction. Always you should rule out hypoxemia as a cause and ischemia as a cause. Echo should be done to assess the ventricular function and any structural abnormality of the heart. MRI of the heart should be considered to see if there is an aggressive immunosuppressive antiviral treatment as triggered bradyarrhythmia. After recovery from COVID-19, permanent pacemaker implantation should be done. The medical treatment of COVID-19 in cardiovascular disease. For example, patients who have significant cardiovascular disease, typically the chloroquine and analog of chloroquine, hydroxychloroquine, are not particularly used because it is a cardiotoxic drug. Then the protease inhibitors like ribavirin or inhibitors like remdesivir antiviral drugs have been used mainly to shorten the recovery time. I mean, to make the recovery much faster in the hospitalized patients, they have been used. But it has shown the randomized clinical trials have no effect on key outcomes such as mortality, ventilation, duration of hospital stay. They have not shown to be beneficial in those areas, but it has shown that the recovery phase of COVID-19 is much faster than this. Antibody therapies like convalescent plasma cardiovascular disease we don't recommend because it causes various kind of antibody-antigen reaction, which causes various hemodynamic instability. So in acute cardiovascular events, we have not used the antibodies. For example, convalescent plasma serum of adolescent patients. So immunomodulator therapies like dexamethasone, like steroids like dexamethasone, have been used in patients who are receiving mechanical ventilation to mainly to fasten the recovery of the pulmonary function test. In acutely ill patients, yes, we have used WHO React working group has shown clinical trials have shown improvement in critically ill patients. Administration of corticosteroids like hydrocodone or methylprednisolone compared with use with placebo, all lowered the 28-day mortality. So before 1 month of mortality from COVID-19 has been reduced by using steroids. Benefits are also observed on progression into invasive mechanical ventilation and need for inhalation. So people who are on steroids early have shown improvement, showed that they require less of mechanical ventilation and less of renal deficient. Most important thing what we saw was in this COVID episode was increased risk of thromboembolic phenomena. So antithrombotic therapies were the mainstay in COVID-19. Apixaban was used, dabigatran was used, endovaxan, rivaroxaban were all used. But in an Indian scenario, where these drugs are not very commonly available in the market, except for dabigatran, we used aspirin, clopidogrel, as well as heparin. Low molecular heparin was also used for a week with good outcomes. Dabigatran must be used cautiously because 70% of the drug viability is there. So it has to be dosed once in a day for COVID-19. Coming to the vaccines, we had COVID vaccines, Covishield, Covaxin, many other brands came. Doesn't matter, but we saw that the COVID vaccines reduced the hospitalization of patients and complications due to COVID-19 infection, as well as reduced the incidence of COVID-19 in cardiovascular disease. For cardiovascular disease patients, we have always advised them to have early COVID vaccination with good antibody titer. There are very few contraindications for vaccinations in COVID situation. Where only pulmonary vasculitis is the only thing where we fear COVID vaccine. Otherwise, there is no other contraindication for a cardiovascular patient who wants to take a COVID vaccine. In conclusion, interaction of COVID with cardiovascular disease is very complex, and it is very well known entity, and we come across everyday's practice. So the careful assessment and attention towards the diagnosis, judicious use of the cardiovascular diagnostic modalities, along with the epidemiological studies like RT-PCR, rapid antigen test, ECG, X-ray, echo, all these things should be considered before considering whether the patient is having COVID-19 infection along with cardiovascular disease or cardiovascular disease because of COVID-19. and always needs a conservative approach in more chronic than the acute cardiovascular disease. Acute cardiovascular disease are acute heart failure, acute coronary syndrome, acute arrhythmias, new onset problems in COVID-19 has to be treated aggressively, and more conservative approach should be taken for chronic cardiovascular disease is the take-home message. Hybrid approach should always be used judiciously, where we should always judge the spread of, we should minimize the spread of COVID infection, also have a really good control of the mortality of COVID. Thank you. Let's go with new ideas and some of the new therapies, cardiovascular and COVID-19.
Thank you, Doctor. Indeed, it was great. You have explained all the aspects of CVD connected with COVID-19. We have got a couple of questions and some doubts on cardiovascular disease. Doctor, what is the meaning of CCS patient?
Very
In Q&A,
chronic cardiovascular, chronic stable angina patient.
Okay, fine. And how common drug interaction between cardiac and COVID-19 medicines?
Yeah, see the anticoagulants what we are using for COVID-19 for increased thromboembolic phenomena. Also, we use azithromycin and hydroxychloroquine in the beginning, which showed some kind of antiviral activity. The azithromycin is a drug which can interact with the anticoagulant what we use. So the anticoagulation efficacy might go up. That means the blood coagulability will become much more lesser compared to patients who don't take azithromycin. There is one interaction we have seen. The second thing is hydroxychloroquine, along with other medications like azithromycin, added upon to reduce the heart rate by increasing the QT interval. So these are the two main interactions we saw with COVID medications and cardiac medications. Other than that, not much of interaction between those.
Thank you, Doctor. The next question would be, what are the symptoms of COVID-related CVD?
The same symptoms, but the most commonest is chest pain, breathlessness, and low saturation. Patient, they monitor at home or they come and say that, sir, our saturation is very low and we are having breathlessness, we are having chest pain. So what we do at that time is we try to analyze whether they have any contact history, whether they have clinical symptoms of COVID-19, like for example, they had fever first or they didn't have any fever. Whether they had any body pain, throat pain, headache, which are more of viral infection rather than cardiovascular. So we think that if they don't have all these symptoms, we know that and patient already had a history of cardiovascular disease. That means more likely that patient is having cardiovascular disease and now contacted COVID-19 infection. Or, for example, a patient had a COVID-19 infection. Now, before that, he didn't have any cardiovascular diseases. Now he's come with heart failure or arrhythmia or acute coronary syndrome, like ST elevation MI or non-ST elevation MI. Now we know that it may be because of the COVID infection. That's how we differentiate and try to treat them.
Thank you, Doctor. And the next question would be on the link between the diabetics and CVD.
Yeah. With high blood glucose levels for any kind of blood instability. Patients who are not controlled, having high blood glucose, will have injury to the endothelial cells of the blood vessels. So there can be a breach in the endothelial cells there. They can have a thrombus formation starting. That is one. Number two, that can rupture and cause myocardial infarction. The ruptured plaque can go into the distal coronary artery and can cause myocardial infarction, as well as stroke. Incidence of stroke in the similar way when it happens in the brain. So both the places in the microvasculature is altered in poorly controlled diabetics for having high blood.
Thank you, doctors. I have a pretty much long question. I think it's related to a patient. Just reading that question from the page. Okay. So 1 month earlier, my father affecting same condition suddenly again pain and 1 hour the result into MI during GA ambo gauge treatment is stop attending nurses and they said shock to be given. High BT patient 145 then expired. My question is, sir, in case of extreme emergency condition due to COVID-19 and serious or respiratory failure patient, what medication should be prescribed except clotbuster, nitroglycerin aspirin 300?
I think they should not, these should not be used indiscriminately. A patient who is having COVID-19 with cardiovascular symptoms and who cannot even stand, speak, or even patients knows that relatives know that he can't breathe, has to be taken to a center where you have to where it is treated properly, where they can treat both the things properly. For example, we have a center where COVID-19 infection is treated along with the cardiovascular factor. It has to be reached there. There, the primary physician, what it does is he quickly evaluates the patient. Now, I understand this patient had a cardiogenic shock. Maybe underlying cardiovascular problem, having COVID-19 infection, or didn't have a cardiogenic problem, but COVID-19 caused him a cardiac problem, which ended up in acute cardiac problem. So now this patient needs to be treated by the cardiologist or the emergency physician who is the hospitalist. We will decide what. So, for example, cardiogenic shock, the blood pressure is fallen down. They will start inotropes so that the blood pressure comes up, because the blood pressure is very important for the other organs to be saturated. I mean, having good blood flow first. And if saturation is less, they'll start him on oxygen. And if they do an ECG and see there is a ST elevation MI, they'll see that the heart, they have a heart attack followed by cardiogenic shock. So the immediate thing is they'll do an RT-PCR, they'll do a rapid antigen test and take him for, if he's deemed fit for, suppose he's a 45-year-old male, no other comorbidity, suddenly comes with COVID-19, classic COVID-19 infection, suddenly comes with acute heart attack, cardiogenic shock. He will be immediately taken to a cath lab, rushed immediately to the cath lab, and try to open up the coronary artery with his block. That is one. Number two, ECG doesn't show any ST elevation MI, and all the other blood investigations show no major heart attack. But patient has suffered cardiogenic shock. Maybe it was directly involvement of cardiac muscle, that is myocarditis, which caused acute heart failure. For them, they will stabilize on giving oxygen, giving inotrope, and getting up the blood pressure. If they have arrhythmias, as I can understand from the question, the patient had something to do with arrhythmia. That's why they shocked him. Once the rhythm comes back to normal, then they will continue with the regular course of medications. Otherwise, this is a very deadly combination. COVID coming with acute heart failure as well as arrhythmias is a very, very deadly combination. The mortality is very, very high. Even with maximum number of, even with maximum treatment, maximum understanding, it is very difficult to make the patient survive.
Okay, doctor, thank you. The next question is something related to dental. Okay, so invasive dental procedures in pediatric patients with heart disease.
Yeah. So timing is very important. If you have an active viral infection in the oral cavity, better to avoid, better to give medication and wait till the COVID-19 infection is settled. Like it will take 2 to 3 weeks. Once it is done, you can go for the procedure. If there is an acute condition like an abscess or something which is more serious, impacted tooth, those things you can always, under the cover of antibiotics, you can always go in, even with cardiovascular disease. Infective endocarditis prophylaxis.
Doctor, can we take 2 more questions?
Yeah.
Okay. Next question is, need advice on cholesterol and heart health.
Yes, of course. Cholesterol, there are 2 types of cholesterol. Low density lipoprotein and high density lipoprotein. High density lipoproteins are protective to the blood vessels, whereas the low density lipoproteins and triglycerides are more prone to develop atherosclerotic heart disease. It can be even in the heart, brain, lungs, or kidneys, wherever it is. All blood vessels have no clots if the low density lipoproteins are on the higher side. So there are various ways. There is one thing is diet, the other thing is exercise, and the third thing is medication. These three are very important.
Thank you, doctor. The next question is, based on my family history, am I risk for a heart attack or heart-related disease?
There are this heart disease is multifactorial. It is not pinpointed to one particular reason why people get heart disease. So it is multifactorial. We always say that the multifactorial in the sense there are multiple factors. Some factors are modifiable, some factors are not modifiable. For example, the genetic makeup you cannot modify. You're already born with certain coding of genes which cannot be modified. So, and our sex cannot be modified. Nowadays they do, but it is not possible as the interior endocrine system cannot be manipulated. So sex as well as genes cannot be modified. So these are the things which are already inherited from our parents or from the genetic makeup that we have. So these things, if genetically we have grown, like our mother had a coronary artery disease, our parents had very strong history, siblings had a very strong history. Not necessarily, but you always have a risk factor in the sense that genetic makeup is such that that cannot be modified. So there are certain things which can be modified. For example, there is genetically predisposed to cardiovascular risk. There are other things which are environmental and which can be modified. For example, diet. Low-fat diet can be used. For example, exercise. You can start exercising. Sedentary lifestyle can be given. Then smoking. Smoking is a very high risk factor for cardiovascular disease. Diabetes, you can always control, as well as the other medications. Some medications can also control the progression of cardiovascular disease. So these are the modifiable factors, but genetical predisposition we cannot modify, unfortunately. But we can take it as a positive sign that we already know that our parents had a cardiovascular risk, so that we can at least see what we can modify to suit the environment, really, of the body.
Thank you, doctor. The next question is, doctor, can you tell more about arteriosclerosis?
Atherosclerosis is kind of a degenerative disease. It's a kind of when there is a blood flow in the blood vessel, the cells are separated by each other and they don't stick to each other. And it is flowing in the artery. Okay? This artery is lined by the endothelium. The endothelium is intact. There is no breach in the endothelium. So the small injury into the endothelium can cause the blood vessels to the blood elements to stick to that place. That is how it starts. But depending upon the blood sugar, depending upon the blood cholesterol, and depending upon the nature of injury caused by the hypertension, as well as the smoking, there is injury to the endothelial cells. So then small cells go and get attached into it. And the lipid starts accumulating into it as kind of a degeneration. The cells die and it is replaced by some kind of a fat cells. So they form a small ball that is called as atheroma. It's called as a plaque. This is how the artery gets blocked. Depending upon where the blockage is, if it is in the main coronary artery of the heart, you will have a bigger heart attack. If it is in the smaller part of the coronary artery, you will have a smaller heart attack. If it is completely occluded, then you will have a big heart attack. If it is partially occluded, you will have chest pain. And it depends on the artery where it is started. This usually starts by the very young age, but it is usually not progressive unless we have multiple risk factors.
Thank you, doctor. The next question is, what is blood sugar and how does it affect my heart?
Yeah, definitely. Blood sugar is something that the sugar present in the RBCs, red blood cells. Okay. Normally, it should be less than HbA1c should be less than 5.5. Okay. If it is more than 5.5, that means for the last 3 years, the red blood cells, our turnover is about 3 months a year. in 120 days, the lifespan of the RBC. This blood cells from the replacement, they should not be sugar coated. So when there is increased blood glucose levels more than 200 for last 20, 30 days, this HbA1c tend to go beyond 5.5. So it becomes 6, 7, 8, 9, 10. Some people come with 12 and all. So they are at more risk of having a acute coronary event. So this has to be under 5.5.
Thank you, doctor. The next question is walking good for heart health?
Yes, of course. Heart, at resting phase, heart requires only minimum amount of blood supply, oxygen, nutrition, everything. Once you start walking, it requires more amount of blood supply. So by walking, what happens is by increasing the blood supply to the heart, you will also ensure that the blood circulation is smooth. But if you don't do that, what happens is it gets adjusted to the limited flow. And the natural size of the coronary arteries will be at the smaller level. And that's how, if the smaller arteries get blocked, they get blocked very, very fast. With the bigger arteries, they take longer time to get blocked. So walking definitely helps.
Thank you, doctor. The next question is how to treat COVID patient immediately if patient suffering severe hypoxia and respiratory failure along with oxygen therapy. What medication should I prescribe for immediate management?
Any bronchodilators can be used. I prefer to use anticoagulants as well as oxygen. These are the only three mainstays. If not able to maintain oxygenation in the blood, then there is no other option than to go for a mechanical.
Okay, doctor. I think, doctor, we have taken up all the questions related to CVD. And if there are any more questions coming up, doctor, okay, one more question is there. Okay, kindly explain about initial COVID patient lung condition, how to identify patient is COVID-19 if patient is asymptomatic by seeing her chest X-ray or HRCT, what confirmatory diagnosis to identifying sure?
RT-PCR is still the gold standard. RT-PCR is negative, you can take it as negative. It is positive.
Okay, in general, patient chest X-ray showing white patches most of the lung.
No, there are some definitives. CT guided X-ray shows patch doesn't mean it is COVID-19. RT-PCR has to be positive. If it is negative, still you are suspicious about COVID-19, then do a CT scan to confirm that. CT scan will differentiate the lung patch, whether it is COVID or whether it is due to cardiac problem.
Okay, doctor. So I think I have taken up all the questions related to cardiovascular disease and how we can manage, what are the basic findings we have seen for the last 2.5 years, by understanding the COVID conditions, and a lot of patients have seen. It would be a very different experience for you in treating the patients with COVID-19 and, heart disease and everything. Thank you, doctor, for spending your evening in detailing all the management aspects of CVD. And thank you so much for the Frontier Lifeline Hospital and the team who, helped us in organizing this awareness session. Thank you so much. Have a good evening.
Thank you. Thank you all the participants. And Soumya, thank you for organizing such a good. Thank you.